Ladies and gentlemen, welcome to this latest teaching session in the course on technology and the future of medicine. Today, Dr. Bibiana Cujec is going to take us through Singularity and the Have-Nots, observations of a Canadian cardiologist in Nepal. Take it away, Bibiana.
Well, it always sounds so formal when you introduce it like that, Kim. But really, I'm here to talk to you about my experiences in a low-income country and the great challenges in terms of progress and improvement in health in Nepal in particular, which is really the only low-income country that I've traveled to. So what I'm going to do over the next hour or so is describe through my own experiences the challenges to healthcare in a low-income country, and give you an idea of the shift that's occurring right now in low-income countries from communicable diseases, so infectious diseases, to chronic diseases like cancer and diabetes and heart disease. And then to have you understand the barriers to the use of technology in Nepal, a low-income country. So first of all, a lot of a country's development depends on its geography. So Nepal is a small country that's squeezed between two giants, China to the north, and India surrounds it to the east, west, and south. And Bangladesh is close by, Bhutan is close by, Pakistan would be over here. And Nepal has three distinct geographic districts. The north is the most well-known. That's where the Himalayas are. And people come from all over the world to climb in the Himalayas because many of the world's highest peaks, over 8,000 meters, are situated here. And many of you probably know about Everest Base Camp treks. That's a very popular trek. And yeah, that goes into the Khumbu Valley, and I'll talk to you about my experiences in a valley close to there. Nepal has 29 million people. And the official religion, well, most people are Hindu, although it is the birthplace of Buddha. About 80% of the population is Hindu. The language is Nepali, although there are many different ethnic dialects, so many different ethnic groups in Nepal. The currency is the Nepali rupee, so a little different than the Indian rupee. And about 80% of the population is rural. And there's great disparities in health between rural and urban Nepal. So comparing Nepal and Canada side by side, the population is not too dissimilar. 29 million for Nepal and about 33.5 million for Canada. But the literacy rate in Nepal is one of the lowest in the world. So literacy rate is usually defined as the people over the age of 15 who can read and write. And in Nepal, about 71% of males are literate and only 47% of females. Life expectancy at birth is an important parameter of the health status of a country. And life expectancy at birth in Nepal for men is 65 years, and for women is 69 years. And you can see how for Canada, it's more than 10 years higher. And life expectancy in Nepal is one of the lowest of about 180, 190 countries in the world, so Nepal ranks 168th from 2009 data. And then infant mortality looks at the number of live births, children who are born, who die before the age of 1 year. And in Nepal, about 55 out of 1,000 live births, 55 children die within the first year of life. And that puts it at a rank of about 138 of the countries of the world. And again, it's much better in Kathmandu in terms of infant mortality, Kathmandu being the capital of Nepal, versus in the mountains, in the hilly regions of Nepal, where infant mortality is about 1 in 100 live children live at birth will die by the age of 1 year. So definitely a poor country. Now, Nepal, the big attraction, of course, are the Himalayas, and people come from all over the world to the Himalayas. And over the years, Nepal has had a lot of foreign aid from non-government organizations. And that's a picture of Ahmedabad in the Khumbu Valley. So in 2010, on my first visit to Nepal, I had the opportunity to observe what it was like in rural Nepal, because we did a 1-month climb in the Hinku Valley to Mira Peak. We climbed Mira Peak, and that's in a valley that's just east of the Khumbu Valley. Now, the Khumbu Valley is pretty famous because Everest is at the end of the Khumbu Valley, and lots of tourists come, and of course that's an important economic benefit to this region. And Edmund Hillary, who is the New Zealand mountaineer, first to climb Everest. It wasn't the first peak over 8,000 meters to be climbed, but the first ascent of the highest peak in the world. Edmund Hillary did a lot of work over many years raising money for the Sherpa people in the Khumbu Valley. So the Khumbu Valley is relatively wealthy. So when you fly from Kathmandu into Lukla, which is the gateway to the Khumbu Valley, you're in this small propeller plane, and it has to land on this little runway that's just built into the side of the mountain. And there's crashes every year with fatalities because of clouds. You know, this is very mountainous country, and clouds move in and out, and it's very tricky to find this runway sometimes. But this is the village of Lukla, and you can see, like, it's an affluent village by Nepali standards. And yet, when we were going through there, we saw the hospital in Lukla, and it looked very nice, but there was a gate around it and a padlock on it, and it was closed. Because although this hospital had been built by a Swiss NGO and it looked really good, there was no operating budget, and there were no local staff to run the hospital. So we saw a lot of this, like NGOs invest in an infrastructure, but there's not enough money to maintain it. So, you know, it's great to have technology, but if no one can run it and maintain it, it becomes obsolete really quickly, and it just contributes to the garbage that countries like Nepal can't deal with. So as we're trekking through, once you leave Kathmandu, like not far out of Kathmandu, there's no more roads. And so there's just these little trails between villages in the mountains. And in our group, well, this wasn't all of our group, but there's a lot of other expeditions on these, going through these valleys. And the porters carry very heavy loads on these narrow trails, and they're often wearing just flip-flops. So pretty amazing. And one of our guides had some respiratory problems while we were maybe 2 days out of Lukla, and he said he had forgotten his medications. So he had to go back home and get his medications. But going home, you know, didn't mean a car ride. It meant him trekking by himself over these trails at high elevation. So life is very difficult there. Only steep trails between villages. And then the homes that we saw in the villages, they were these little huts built of stones and sometimes tin roofs, sometimes wood, but there's not much wood in the alpine regions, of course. And you can see here there's a chimney, but they would often block off the chimney to try to keep the heat within the home. And that creates a very smoky environment. And there's a very high prevalence of respiratory diseases because the homes are heated with these little fires in small spaces that are unventilated. So you're inhaling a lot of particulate matter from the smoke, and that causes chronic obstructive lung disease over the years. And we saw a lot of that in the hospital in Kathmandu where we worked. And then there's lack of sanitation in these villages. So, you know, no toilets with running water. There's outhouses, but the outhouses are basically like a hole in the ground with some boards, and the boards are kind of rotting. So you're always afraid they're just going to break when you're in there. So the outhouses are pretty horrible. And most people just defecate out in the open. So obviously that's horrible for water supply. And diarrheal diseases are rampant. It's still a major problem. Lack of clean water and adequate sanitation. It's a huge problem. And on our climb, when we were coming back down, actually, there was a German tourist, a German climber, who was evacuated because of diarrhea, gastroenteritis. And you know, the weather was okay, so the helicopter flew in and plucked him out of the valley and took him to Kathmandu. And that was That was great because he had good health insurance. But when a local porter became sick at high altitude, he just, he was very sick and he wasn't thinking clearly, so he just wanted to be left alone for the night, and his friends left him alone in a little hut similar to this, and when they came back the next morning, he had died of high altitude pulmonary edema. So very different health care for foreigners who have health insurance and locals who rely on their friends because you only get the health care that you can pay for. There's not much government subsidized health care. There is some, but mainly for children, but not much. So my first visit to Nepal was to climb in the mountains, but then you become very attached to the people you meet. And like many other people, I initially came for the mountains, but then thanks to Kim Solas and other people here at the University of Alberta, I went 3 more times to Nepal to teach at a new medical school that they developed in Kathmandu. So Kathmandu is obviously very different from those small villages in the Hinku Valley. It's a very sprawling city of about 5 million in the valley, and it's a valley that's prone to earthquakes. It's surrounded by hills, but often you can't see the hills because there's so much smog, and the smog comes from brick factories. You can see here it's quite cloudy and smoggy. Brick factories, and then there's all these trucks that spew diesel fumes, and people burn their garbage at the side of the road. So it's just very polluted, and it's invariable if you stay in Kathmandu for more than a day or two that you kind of start coughing. And it takes a few weeks when you return actually for your respiratory function to come back to normal. That's what we notice when we go there. And then the other problem, of course, is diarrhea because of the poor sanitation, and I'll come back to that. But Kathmandu is very dirty. There's garbage all over the place. There's like a lot of dogs that wander the streets. They don't attack you. They just coexist. They tend to sleep during the day, and then during the night they'll bark. There's monkeys, there's cows. The cows are sacred in the Hindu religion. And there's a lot of motorcycles. Traffic is a little chaotic, but nothing like India. And there's people carrying heavy loads, small cars. It's a noisy place during the day, but at night it's very quiet because many parts of the city have no electricity. Intermittently, there's blackouts in different areas because there's not enough electricity to power the whole city. The electricity comes from hydropower from the Himalayas. So especially in the winter, when the Himalayas are frozen, there's lack of power. And there's periods of up to 16 hours where there's no electricity in Kathmandu. It's very, very different. So I went to teach at this medical school in Kathmandu called Patan Hospital on 3 occasions. The first time was in the monsoon season in July, and the second time was in the fall, so that was actually a really nice time of the year, and then most recently in January. And that was a very cold time of the year because there's no central heating, so we had to wear our parkas indoors, and it's a challenge to work at night because it just gets so cold. But this is a picture of the hospital. I'll tell you a little bit more about the hospital later. And we went as part of the cardiovascular block and taught and helped the local faculty in terms of developing lectures and exam questions and small group teaching cases. And then we taught clinical skills as well to the medical students. And this medical school is very innovative. Its purpose is to educate physicians for rural Nepal, which is the poor part of Nepal. So these students, many of them come from rural Nepal, and the school uses the best educational methods in terms of giving them a good education. So we did a lot of problem-based learning, and this was one group that I had last year. We have a lot of visitors as well who come. This is a professor from the University of Calgary who is visiting, and the students are just like, they're just so happy to be there despite all the challenges that they face. And just like they love to learn, they're very enthusiastic participants in any discussion, but it's hard for them to have resources, because the internet is down part of the day. They have some textbooks, but not, they print, they photocopy whole textbooks whenever they get their hands on a good textbook. So a lot of challenges. They tend to remember things really well, they memorize well, and a little harder for them to kind of have deductive reasoning and analysis of data. But yeah, they're very young too, directly from high school into medical school. That's the way it is in Nepal and many other countries in South Asia. So what was impressive to us was the great community spirit. So this is where we rented the bottom floor of this building that's owned by an ex-Gurkha soldier. And it was unheated, but lovely garden that the woman who owned the house looked after. And just a lot of life in the back alleys. Like people there there wasn't much technology. So people really depended on each other for help. And they just kind of enjoyed being together, and there'd be a lot of singing and dancing on different occasions out in the street. And we got water. We had these big jugs of bottled water, and basically came from these deep wells that were dug. And in our own neighborhood, there were several of these wells. We would notice them on our morning walks. And the water would be, it's like, I don't know, 300 or 400 years ago, the water would be pumped up. People would use buckets, basically, to bring the water up and then fill up the large jugs that we had. And then we would pick them up from our little corner store. But it was kind of a very rural, basic primitive way of life. And things took time. Everything took a lot more time than when you just turn on a tap at home and you get clean water coming out. Really appreciate that when you come back to Canada. So the hospital that we were at, the Patton Hospital, is considered one of the best hospitals in the Kathmandu Valley. It has had a lot of foreign aid over the years. It was established in 1953 by the United Missions to Nepal, which was a group of Christian organizations, established during the cholera epidemic. And cholera is still common in Nepal. It has large obstetrics, pediatrics, and orthopedics departments. And the hospital revenue comes mainly from patients, so people have to pay for whatever they have. Like if they need a medication, the doctors will write out a prescription for the medications. Then the family has to take that prescription to a pharmacy, buy the medication, and bring it back. And if it's intravenous medication, the nurses will administer it. But the family is looking after the patient in the hospital. So I was really struck by that. And they had some new services in the hospital, like echocardiography, which is what I do, cardiac ultrasound, and gastroscopy, and they had an intensive care unit, and they had just started hemodialysis. But when all this equipment breaks down, there's basically no replacement. They have to just wait until another foreign donor comes by and gives them some other piece of equipment. It's quite different. So we saw a lot of equipment that was just kind of in the corner, gathering dust, not being used because parts were broken. So the first year when I went, they had this echo machine that's kind of not a great machine, but it was working. And so obviously whatever we do there, we want to teach the local people so that when we leave, they can continue using the technology. And so I was training an internist there, how to do echocardiography, and that was going along really well. But then when I came the next year, the adult transducer had broken, and so the machine couldn't be used in adults, so they didn't have any echo. So and echo is cardiac ultrasound, like it's really important for the diagnosis of heart disease. So that was a little discouraging the second time round. So my last visit, like in January, we brought a little echo machine, and you can see how very small it is now. This is a V-scan from General Electric. It's very tiny, but it gives very good pictures. It's not like the full scope of cardiac imaging. It doesn't have everything, but it has enough information to be very useful in an intensive care unit to examine the heart. And so, again, we worked with the local residents and physicians to teach them how to use this machine, and we left it with them when we left. But here you see one of their intensive care specialists doing an echocardiogram on a patient, and these are doctors in training, like specialists in training. So, you know, what I learned there is you do the best you can with what you have, and you try to improve things in whatever way you can. But it's not at all like working here. So this is kind of the typical patient that I deal with here in Canada. And I'm just going to take you through this because it just shows how much technology we have access to here, and how chronic diseases are very prevalent here. So this was a 66-year-old man that I looked after for several years. He was obese, and he had diabetes and hypertension, high cholesterol. He was a previous smoker. When he was 52, he had a large heart attack, and he was treated with a medication that dissolves clot, and then he had angioplasty of one of his coronary arteries. But he had suffered a large heart attack, so there was a significant scar in his heart, and his ejection fraction, his heart function, was moderately decreased at that time. And he did well for 6 years, and then he started getting more chest discomfort, and he had another angioplasty. And then 2 years after that, he started developing heart failure, so shortness of breath and fluid retention related to poor heart function. So he had to take a lot of medications every day to control the heart failure and his diabetes and the high cholesterol, so lots of medications. And then he had, because of the large scar in his heart, he was likely to have significant rhythm disturbances and die suddenly. So he had a defibrillator implanted. But technology has its problems, and that defibrillator became infected and had to be taken out and a new device implanted. So he spent some time in hospital on antibiotics. And then 3 years later, our technology in medicine, it helps people live longer, but it doesn't really cure them, most of what we do. So they live longer, but then, there's other problems that come up over time. So 65, he's got worse heart failure, comes into hospital a lot. He has kidney failure now too. And then when he's 66, he has repeated shocks from his defibrillator because his heart becomes so irritable from an electrical storm. Just very frequent fast heart rhythms. So now, he's really sick from his heart failure, and we assess him for a heart transplant. But he really wasn't a candidate for that because he had too high pressure in his lungs, and he also had renal failure. So then he had like a mechanical heart implanted, an assist device. And he died a few days after that of complications. But over about a 14-year period, he had a lot of technology, some of which had complications. And finally, he had our most sophisticated device, which is a mechanical assist device. And he died despite that. But a lot of technology here. High-tech, chronic diseases, and very, very costly. And this is a patient that I saw in Nepal. And I wrote for one of our medical school journals, I just wrote a little section about this patient, and I'll just read it out to you. The boy stares unblinkingly at me. He is very thin and worn out from heart failure. He is 17 years old and has been readmitted to the medical ward at the Shahid Gangalal Heart Center in Kathmandu. I look at his chart. His mitral valve has been destroyed from repeated bouts of rheumatic fever, a preventable infection related to streptococcal infections. He has severe mitral regurgitation and left ventricular dysfunction, so severe valve problem and heart failure. He is dying. In my 30 years of clinical practice in Canada, I've seen only 2 cases of acute rheumatic fever. This boy has had many episodes of acute rheumatic fever during his short life. In the ECG lab, there's a curtained-off area where patients line up to have their intramuscular injections of penicillin every 3 weeks to prevent recurrent rheumatic fever. In this National Heart Center, there are more cases of mitral balloon valvuloplasty for rheumatic fever annually than there are percutaneous coronary interventions for age-related coronary artery disease. So people don't live that long, and so they don't develop coronary disease as frequently as they do in Canada. We have so many sophisticated cardiac interventions in Canada, like implantable defibrillators, percutaneous valve replacements, heart transplants, ventricular assist device. On the other side of the world, however, people are dying because of poor sanitation and living conditions and preventable infections. And this boy, I'm sure he died within a year after we saw him, because it was just too late to do anything at that time. So this is really about poverty and social inequity. Very different faces of heart disease in Nepal versus Canada. Nepali patients are younger. Infection is still a common cause of heart disease in Nepal, whereas in Canada it's much more degenerative, like disease of aging. Cost of care is really cheap. Penicillin is not very expensive in Nepal, but very expensive for chronic diseases in Canada. So the World Health Organization data on Nepal indicates that many deaths are still due to infections, maternal and perinatal complications, and malnutrition. Because of the poor sanitation, diarrheal diseases are rampant, pretty much guaranteed to get gastroenteritis if you're in Kathmandu for any period of time, no matter how careful you are. And acute respiratory tract diseases are also very common because of the close living conditions and the pollution. Vector-borne diseases are still very common, like in the intensive care unit we saw many cases of malaria and tuberculosis. And in addition to these infections, now we have increasing diabetes, hypertension, coronary artery disease, and cancer. So chronic diseases are also increasing as life expectancy increases. So coronary artery disease is becoming more prevalent in Nepal with the aging of the population, urbanization, so the move to Kathmandu and Pokhara in the larger cities, decreased exercise as people move from their farms. They like a lot of fried foods, so the fatty and salty diet is particularly bad for them because South Asians have a genetic predisposition to coronary disease. They tend to have very small arteries that are diffusely diseased. So the major challenges for Nepal in terms of healthcare are the unstable government and rampant corruption. So they went through a civil war in the 1990s with Maoists fighting in the villages, and a lot of people moved into Kathmandu. And the government is just, there's a coalition government, and they just don't seem to be able to pass any bills and ensure that hospitals and schools get adequate funding on a regular basis. And corruption is rampant at all levels of government. It's quite interesting. The people seem to know who's corrupted. Like, we had a speaker come in, several speakers from the government come to the hospital, and one of the local doctors mentioned that one of them, is uncorruptible. Like, that was a great compliment to say he was uncorruptible. Really lack of a reliable infrastructure. The roads are in poor condition, and bus transportation, well, it depends on what the roads are like, so often can't go between towns. Electricity, dependent on hydroelectric power that is not always available. Living conditions are very crowded, poor sanitation and lack of safe drinking water. So all this creates poor health. Poor nutrition, pollution, vulnerability to disasters just because where Nepal is located, and then the social and health inequity, that's a consequence of a lack of good government. It's not that Nepal doesn't have resources. It does have some really good health facilities, like this heart center, but the problem is patients can't afford to get care to get more specialized care. So in this heart center, they do a lot of heart operations, although many of them are for congenital heart disease and valve replacements because of rheumatic heart disease, much less bypass surgery. They definitely have good technology, but not many people can access that because they just can't afford it. So here's a state-of-the-art echo machine at the heart center and a cardiac catheterization laboratory. So this was one of our interventional fellows, one of our cardiologists here at the Heart Institute. She came with us to teach at the Patton Academy of Health Sciences, but she also got to spend some time in the Heart Institute, and these are some of the other cardiologists who work at the Heart Institute, and they are very concerned about the increasing number of young patients with heart disease, in addition to the rheumatic heart disease that they've been dealing with for many years. So not just in Nepal, but in other low-income countries, there's a real concern about the epidemic of cardiovascular disease that's in addition to the endemic infections that they have. So places like Nepal have a very hostile cardiovascular environment, especially with the urbanization of a population that used to be rural. So tobacco, a lot of smoking and secondhand smoke from fires that they use for cooking. HIV survivors, air pollution is a big one. And then there seem to, in South Asian population anyways, India, Bangladesh, there's a genetic phenotypic vulnerability to coronary artery disease, so more likely to have diffuse disease. And then of course these countries have very limited resources to deal with these health issues. And many of them are societal and environmental. It's not even like high tech that's required. It's just clean water and air that would make a huge difference in terms of health. So this medical school that we've been working at is the Patton Academy of Health Sciences, and it's a new government-sponsored, a public medical school with a mission to train doctors for rural Nepal based on the principles of social justice and equity. And it's really amazing how this man, Dr. Arjun Karki, who's a pulmonary specialist from a town in the outskirts of Kathmandu, basically trained in the United States at Johns Hopkins, and he wanted to make a difference for rural people in Nepal. So this medical school is basically his doing. It's put all his energy into this and garnered support from many experts in medical education and specialists in different areas to come and teach and develop curriculum at this medical school. And he's also very politically connected in Nepal. Every year, like Dr. Soles has been involved with this medical school since before its inception, but every year a group of international supporters and experts in different areas of medicine meet in Kathmandu and often meet with the Prime Minister as well. This was a meeting in October. And from Alberta, from Edmonton, we have David Zakas, who's our Director of Global Health. And here's Arjun Karki. Bob Woolard is from University of British Columbia, as is Caroline Cornea, and Ken Lukoviak is from University of Calgary. So a really strong Canadian presence at this medical school. The resources are pretty basic in the medical school. It's attached to the hospital, the Patton Hospital, which has been around for a long time. But it basically has 2 classrooms, there's 60 students, 2 classrooms, a few textbooks, good quality textbooks, and then these are the rooms for the small group sessions, the problem-based learning, and there's a small computer lab. Very cold though in the wintertime because there's no heating. The program, the medical school program, is 6 years in duration, and they get students preferentially from rural Nepal. And they have a good screening program. Like they're really trying to attract students who are altruistic and caring. So they have special psychological testing, like to try to discern who has those qualities. Many of the students are on some sort of scholarship so that they then will return to rural Nepal to work. And tuition, you see, is very expensive, so that's why these students need scholarships. And the whole goal of the school is that these doctors will work in rural Nepal, which is very poor. So right from the first year of medical school, they have rotation. In these countries, people don't travel much. You basically just work, you just live in your own small, I don't know how large it is, but it's pretty small, like a mile maybe, 1 square mile. It's very small, and you don't really travel anywhere else. So many of the students who are from Kathmandu had never been out into the villages. So in this medical school program from first year, they have to go live with families and see what life is like in these rural communities. And once they've worked in a rural environment, then they have a priority to come back for postgraduate positions and to become a specialist, which is what some of them definitely would want to do. So telemedicine support is really important when these students will be out in rural health districts. But there are a lot of challenges, like with internet connectivity and availability of power supply. They're really basic things. So very different than like here in Edmonton, where, for example, we have a very sophisticated system for dealing with acute myocardial infarction with heart attacks. So a patient complains of chest pain, calls 911. We have an ambulance with paramedics who are trained to do electrocardiograms and start IVs in the home. So the paramedics do the electrocardiogram, and then they transmit it to a cardiologist or an emergency physician who looks at that electrocardiogram. And if there are signs of a heart attack, then the paramedics can administer medication to dissolve blood clot, fibrinolytic drugs. So, remote diagnosis and directed therapy, I wouldn't say it was simple, but it was feasible in our environment with the technology that we have. And it's great because it makes a huge difference for the prompt treatment of heart attacks and better long-term outcomes because there's less heart muscle that's affected and that dies from the heart attack. And Peter Wood, who's a postgraduate student here at U of A and who took this course last semester, he's working on developing a telehealth system that will be very portable. And hopefully we'll be able to take it to Nepal as well, but it'll be useful for rural Alberta as well. So it's pretty amazing what we can do with the technology that we have now, these portable device units with medical sensors. Like even with your iPhone, there's now an application where you just, on the back of your iPhone, you just apply a strip and then you can put 2 fingers on it and you'll have a rhythm, your heart rhythm will be displayed on the screen of your iPhone. So very nice. This is a little more sophisticated. We can get a full ECG with this. And then this data is transmitted to a server, and then of course experts from any location can look at the data and make a recommendation about diagnosis and treatment. And there are many possible sensors that can be attached to these remote devices. So blood pressure, heart rate, oxygenation, temperature, blood glucose, respiratory capacity, electrocardiogram, and all of this type of data can be transmitted to a server. Very good for dermatology. And so, wherever the patient is pretty much in the world, they can be hooked up to this portable unit with all of its different biosensors, including, this is what we brought to the ICU in the hospitals, the GEV scan for portable ultrasound of the heart or of the abdomen, and all that can be looked at remotely, and an assessment of the patient can be made remotely. So there's certainly a lot of potential to improve health in remote areas, but there's a lot of problems too. What I observed, like at the heart center there and in the hospital, was just, people come to the hospital when they're acutely sick and they're looking for a simple solution because that's really all they can afford. They don't like taking any kind of medications on a long-term basis. They're only going to take them when they're feeling sick. So imagine what that would be for our chronic diseases like hypertension and diabetes. You wouldn't take any pills for that until you feel really sick. So they love antibiotics and they overuse antibiotics in Nepal. But other things work really well if you have the right condition. So for example, if you have a problem with the mitral valve where it's not opening up well, then it's really easy to fix that because they reuse the catheters that are used to open up that mitral valve. Surgery is expensive, but these catheters are much cheaper, especially because they're reused. Pacemakers also is usually not that expensive. And really the simple technologies that don't require any maintenance is pretty much all that they can rely on. So cell phones, internet. Cell phones work very well in Nepal, and everybody has a cell phone, it seems like. You can see this is a picture that I took in a monastery in the outskirts of Kathmandu. And these monks, well, they're on their cell phones, just like people are here. So 70% of the world's 5 billion cell phone subscribers are in the developing world. So lots of cell phones. 90% of the world's population has access to a wireless phone signal. And even in remote villages, people have mobile phones, many of which are web-enabled. So what this has resulted in is what Thomas Friedman, the columnist for the New York Times, calls the rise of the virtual middle class. So these are people who are still poor. I mean, they still don't have clean air and water and good living conditions, but they're aware that other people in the world have that, and they're demanding of better rights and better infrastructure and better education and uncorrupted police force. So they expect more. Technology can definitely improve life, as many of these smaller companies have improved supply of power, glasses, of safe drinking water just through cell phones mainly, by telling people when it costs less to use power and where to get safe drinking water at different times. But life in Nepal is still a lot more difficult than it is here. And this is just from a synopsis of different newspaper articles in last fall. So about corruption, politicians offer meat and liquor for votes. Illiteracy is still very common. Serious hunger problems, well, Nepal is improving. It's 49th out of 120 countries instead of 60th out of 120 countries. Lack of toilets, still a problem. Lawlessness is really scary. Hospital workers and doctors are attacked when a patient dies. You know, I mean, that just doesn't, we may get sued here, but that's a little different than being physically attacked. It makes it very unsafe. Poor infrastructure, so lots of people die in motor vehicle accidents. Violence is common, rape laws are not enforced. They still believe in witches in villages, and 80 to 90 witches are killed annually. So it's hard for us to understand this. Traditions and magical beliefs are very prevalent, so for certain festivals they drown goats. So it's hard to see how, when there's such lack of education and lack of basic resources, hard to see how technology could survive in this environment. Because technology requires a lot of educated people and a lot of maintenance and updating. So science and technology are products of affluent countries, and they certainly benefit the citizens of those countries in terms of quality of life and improved health. But low-income countries are left behind because of lack of education. I mean, if you're illiterate, pretty hard to use some of this technology, and lack of skilled workers. And it all comes down to a lack of infrastructure and a lack of political stability. Good government is just so essential. And some analysis by economists have shown that even cell phones, which seem to have made a difference, haven't really improved living standards in low-income countries in terms of per capita GDP. So very concerning that as technology improves in our society and gives us access to so many choices, the world will be split into have and have-nots. And the have-nots know what they don't have, and it matters to us because the spread of infections from those countries, like cholera, that spread from Nepali UN workers to Haiti, and other infections, very highly resistant tuberculosis that spread to Canada from some of those countries, like India and Nepal. So it definitely matters to us in terms of our well-being as well. So the lack of technology in the have-not countries is a big concern. And basically, I think education and sustainable aid is really important to allow technology to be helpful to the people in these countries. So they need local policies to promote education, human capital, and technological capabilities. And not just the hosting of production facilities, but strategic partnering and developing tools that are helpful to them in their own environment. So technology is wonderful, but the technology that Nepal needs is things like this: clean water and sewage management, pollution control. Everything that we take for granted here, well, they still need it. Improved infrastructure, roads, electricity, housing. The housing is extremely crowded. Improved health through vaccinations. They have a pretty good vaccination program, but not nearly as good as ours. Improved maternal health, nutrition, diagnosis and treatments of communicable and non-communicable, so they need help in both areas. Telemedicine, very important. Smartphones with peripheral diagnostic devices and remote monitoring, diagnosis of problems. And then the research needs to be focused on some sort of database development. They need to have better numbers of the illnesses that they have. Like WHO has very little data on Nepal. Well, there's disadvantages to technology as well, and some of which I think we need to be aware of as well. Technology obviously requires a lot of maintenance and troubleshooting, and that's not a problem in North America in general. In a country like Nepal, though, technology, if it's not maintained and just becomes obsolete, like they don't have good recycling programs, so it just creates more garbage and pollution. It's kind of like the oxygen tanks that have accumulated in Everest Base Camp. And now if you want to go on an expedition to Everest Base Camp or to climb Everest, you have to bring back several kilograms of the garbage that's accumulated there. So it's a really big issue in these countries. But what happens with technology, like in our society with all the technology that we have, and what I noticed was wonderful in Nepal, was that they enjoy simple things, like being together with each other. There's a lot more touching of each other and just a closeness of the people there. Life is slower, it takes longer to do things. But you really have to wonder sometimes what we're really rushing for, like what is so important? And how disconnected technology has made us. Like there's so many people who are walking along and talking on smartphones instead of noticing what's around them. So sometimes technology creates barriers, decreased sense of community and physical togetherness. And technology creates health problems as well. And it's just a really recent article in the Canadian Medical Association Journal from March. And this was a study out of Hamilton. Televisions, computers, and cars, the more you have of those, the sicker you become in terms of higher prevalence of obesity, diabetes, and hypertension, often related to inactivity. So it's not that technology is without its problems. We maybe need a little less, and Nepal needs a little bit more, but certainly I've learned a lot from living in Nepal. And some of the lessons I learned was the importance of simplicity and community, because complicated things break down and then they're too hard to repair. So simple things are best. Community, physical togetherness, and avoiding over-reliance on technology. And Sherry Turkle, this psychologist and economist from MIT, wrote this book, Alone Together, Why We Expect More from Technology and Less from Each Other, and how that often creates a life that just is not well lived. Important to dream big, try to make big changes, like Dr. Karki, developing a new medical school with a unique mission to improve health. Being open to new adventures and taking risk. I mean, for me, going to Nepal, every time I go to Nepal, even though it's been 4 times now, I'm always nervous because I don't know if this time I'll get really sick and die there because, I may not be able to access good quality care. So I always have trepidation about going. Always an adventure. But on the other hand, when you can't rely on technology, you rely on other people and you know that they'll do the best they can for you. Like this is Sushila, who works in the office of the Vice Chancellor. And, if anything happened, she's the one we'd contact and she'd do whatever she could to help us out. And the other thing I realized is how different culture, I think we always see the world from a certain perspective. We don't realize how cultural that is until we go somewhere else and understand how very different they can see the world. So I'm just going to read you this from one of the doctors that gave me a great insight. So Suraj is one of the Nepali tutors for the problem-based learning small groups. He has his MBBS degree and is applying for residency positions. He is very bright, and he asks me many questions about cardiovascular problems and about healthcare in Canada. Suraj was employed by a foreign non-governmental organization and traveled by foot from village to village in remote areas of the Himalayas as part of a healthcare team from Switzerland. I asked him what it was like in these regions. It must have been so beautiful. And he replied, I was cold, tired, and hungry. And I reiterated, but it must have been so beautiful in the Himalayas. Patiently and without expression, he repeated, I was cold, wet, and hungry for 3 months, and I could not relate to that experience. Because, when we go to the mountains, we go with all our wonderful clothing and lightweight equipment, and we go for a short period of time. It's very different when you have to survive in such a resource-poor, hostile environment. High altitude, not enough food, not the right clothing. So I've never been cold, wet, and hungry for 3 months, so there's no way I could relate to that experience. All I saw was the beauty of the Himalayas, and he saw the harshness of life there. They're just very different. So, that helps me. That kind of experience changes you and just makes you more open to other people's perspectives. And that's helped me in my practice here as well, because everybody has different experiences. And when you help others, it comes back to you. We always feel that we get so much more from our time there than anything that we contribute, because it changes your own perspective, makes you realize how lucky you are and how, I think here we rely a lot on technology and we don't realize how it can all fail us. And pretty easily, too. Big planes go down, earthquakes, typhoons, maybe not in Edmonton. Edmonton has tornadoes once in a while. But technology can't prevent those things. The power of nature is pretty amazing. We have our avalanches. And really, you don't need to travel to do all this. Like, there's so much that you can do in your own communities in order to help other people. So in addition to the community of physicians and basic scientists that I got to be a part of when I was in Nepal, it also strengthened my own community here in Edmonton at the University of Alberta. You're not in this picture, Kim, but these are other doctors from the University of Alberta who also go to work at this medical school. And it's enabled me to have a connection with people that I would not normally meet. And that's just so enriching to your life. So I'll just let you read this quote from Albert Schweitzer, but just always being aware of other people who are less fortunate. And spending time with them. Because even if there's not much you can do, sometimes just bearing witness to what they're living through is important to them. So thanks very much for your attention, and I hope that I've managed to portray some of the difficulties of life in Nepal and how technology is wonderful here, but it does require an infrastructure that just is not present in some low-income countries.
Just to emphasize what Bibiana was saying about your own community here, she and I actually met there, right? So, I mean, we probably walked the same hallways here for years, but we never met until we were both in Kathmandu. So, are there questions? There must be questions. Pass it down this row. Let's see what happens.
Okay, I have a question. So you mentioned you have experience with both healthcare systems, and you mentioned the two using a heart patient. So you mentioned that in our system, oftentimes life is prolonged. We can't cure the disease, but it prolongs it, and I get the sense that the quality of life is not there when you're nearing the end. And you contrasted it with a system that obviously has problems as well, but where do you see the middle ground? Like where do you see the ideal? Because it could be that, prolonging life by 20 years is not ideal if you're, sick and tired the whole time. So where do you kind of see the middle ground in that?
Well, I deal a lot with severe heart disease, so people who are dying. And, technology, like you said, sometimes it comes at great cost to quality of life. So there can be several months, even a few years, of very poor functional status and a lot of discomfort and disability. And I think what's really important is to have communities of support during that period of time. So the best would be to take the technology we have and have that and combine that with like the strong family and community support that a country like Nepal has. So no one wants to die alone. And many people here do, unfortunately, because the families are small, they're spread all over the place. If you haven't had close connections over the years because you've been too busy doing whatever, it's very hard for that, for those families to reunite just when someone is dying. What often happens is, the son or daughter comes from Toronto and they say, well, I want everything done to my parent. And they don't realize how that parent, because they haven't seen that parent for a year or two, they have no idea how that parent has become really disabled from heart disease and how it's not realistic, really, we have nothing that will make them better. It's very hard to accept that, death is inevitable and it's coming now and there's nothing we can do to prevent it. And it's not that, those families are very tight in Nepal, they're very close. Death is always hard to accept, but I think it's still better to die surrounded by family members than to die with nursing staff, who are overstretched and don't have much time for you. So it's pretty lonely here at end of life sometimes. So I think the technology is important, but I think it's really important to spend time with other people face to face and build those communities. It doesn't have to be a blood relative. It can be really close friends, but you have to spend time with them. I just don't think virtual communities are going to do it at really critical points in your life. They're a poor substitute.
You spoke quite a bit about how Nepalese,
yeah.
Nepalese, there you go. So they would only come into the hospital after like an extended period of time, after their, symptoms got to the point where it was, they had to get treatment. And I don't really know how feasible this probably was in your case, but was there any ideas of maybe like an outreach program? So instead of the patients coming to you at a time where they're so into the course of this disease, instead you go out there to educate the public in any sort of way to, make them realize that it's just a lot better to come in earlier instead of waiting for this inevitable time where it'll be kind of hard to save them?
That's a slow process, the education of a population about risks, and measuring blood pressure, cholesterol, and money. People just don't have the money to spend on medication. So in general, they come in after they've had some sort of acute event. Either they've been hit by a motorcycle, or a lot of them are falls from buildings because there's scaffolding that's pretty unstable, and they don't have any kind of safety harnesses. So they come in with broken bones, or they come in with head trauma. They come in very sick, or they come in with a fever, and they expect antibiotics. So, it was funny, when we talk about valve disease, we always say how important it is to see the dentist on a regular basis, like once a year, maintain good dentition. Well, that was unheard of from them. They only go to see a dentist if they have a sore tooth or some sort of pain in the mouth. Yeah. So outreach, I don't think they're really ready for that yet, I think they need more education, like through their newspapers, about chronic illnesses and how important exercise is and not smoking. But having said that, it's really hard to exercise in a place like Kathmandu. Like, it's just so polluted. So just things are very complicated there. And the lack of the lack of universal coverage for healthcare makes a huge difference. When people have to decide whether they're going to spend money on food or spend money on medications, but they really can't do both.
I don't know if I'm allowed to ask questions because I'm visiting, but this summer I had the opportunity to visit rural Tanzania for a couple months and to work there in the healthcare.
In Tanzania?
Sort of, yeah. Okay. And your presentation had a lot of similarities to some of the things that we saw when we were there. Towards the end of your presentation, you talked about the need for infrastructure development, and I was just wondering. Well, at least in my experience, I saw that a lot of the locals, when we were there, didn't seem to place a lot of importance on medical infrastructure because their very basic infrastructure was not available yet. So I was just wondering how you really, I guess, the projected path you see in Nepal of, in terms of local perspective on infrastructure development in the medical field. I don't know if I'm being clear. Sort of that transition from basic infrastructure development to medical development.
Yeah, I mean, it's a big problem. I always feel medicine's like the icing on the cake. It's not the cake. Like, the cake has to be the societal structure, and just access to a home that provides appropriate shelter and clean water. And medicine, we treat diseases with variable success rates, but the best thing is prevention, no question about it. And when we look at what happened in Western society, tuberculosis was declining before the advent of antibiotics. It was just in the 1930s, as societal infrastructure improved, that tuberculosis started to decline. So I think you have to have good politicians. You have to have people who are educated and want to build those resources. I don't really see myself as being able to to do major changes like that. Although our medical students, I have to say, have been extremely active in improving clean water in Kenya. Through that project, basically it's ceramic pots that they've taught local people to make out of the supplies that they have, the earth they have, I guess. They make these pots, and then they can pour the water into those pots, and it's a filter basically. So that's a wonderful project, and I really think that's most important, like clean water. So our medical students have been are much more knowledgeable in this than I am.
Are there cases in which, like, some of the people will buy a cell phone instead of, like, food or medical care? So I've heard of cases, because I was on a social justice committee when I was in grade 10, it was more focused on the modern global slave trade, but they're saying that often that a family might sell a child in order to buy a TV. Is that something that was evident in Nepal as well, or?
Well, I have to say, like, from my observations in Nepal, I didn't really see, like, terrible malnutrition like occurs in African countries during famine. So the diet is pretty basic in terms of a lot of rice and lentils. And people tend to be thin, but not starving from what I've seen. And the cell phone does seem extremely important, but having said that, cell phones are very cheap, and especially like you buy these little cards in the store with the minutes on them, and they're so inexpensive. So I wouldn't say they're going without food for that. And medications are also very cheap. Like that is very inexpensive, I have to say, especially antibiotics. But the point I was trying to make, I think, was that just like for chronic illnesses, you need like quite a few medications to take every day. And I didn't see that in Nepal. Like I think it's that they just don't believe in taking a medicine for something that's not bothering them. Yeah.
I have a question. Like you mentioned a lot about changing society and the government and finding solutions for Nepal. And I'm just going to go back to that. In terms of the government, do you, in your experience, know whether they're considering implementing, say, universal healthcare? And if they are, like, do you think they have the capacity in the future of ever doing such a thing?
Okay, I'm going to the government in Nepal seems totally ineffective. They're not even able to supply hospitals with regular operating budgets. So, and they do have some universal health coverage, but mainly for children. So I think the government is just so unstable and corrupt that it doesn't have any long-term plans. That's from what I saw.
It's a remarkable difference. You come to respect the people that you interact with there. But when you go to, transparency.org and those sites that tell you which are the most corrupt countries in the world, this is obviously one of those. So there's a background, corruption there that one has to acknowledge and that influences everything. It's not just that, it's this, inertia of the fact that there's a stalemate at the highest level of, government of not really having an active leader and all sorts of things not happening. So it's hard to imagine universal health care being passed and funded in a setting like that. I wanted to say one other thing, which is part of the unique history of this course. When Bibiana and Earl first presented in this course, they presented on the same day, and Earl heard this account of the porter who died, and he had a completely different view on that. If you believe in karma and sort of traditional beliefs, the other way to look at that is that person felt that their time to die had come and said, leave me alone, I think it's my time. And in the morning they were dead. And it might have been, at least according to their beliefs, the best possible way to go. It was planned for. The patient was conscious, had made this was when it seemed like it was the time to die. If we'd rushed in with Western medicine and saved him, conceivably could have messed up his karma big time, led to some sort of chaotic middle ground between being well and being sick and so on. I'm not saying that that's right, or that the other Western way of looking at it is wrong, but it's very, very interesting to have that other point of view, that maybe what happened there was perfectly okay. Maybe it was completely all right. Maybe it's the way things should have been. I think we'll have one more question and then that,
Me again. So I was actually going to tie back to the fact that you were talking about long-term diseases being very difficult to treat, and a little bit tying into what Sarah was saying. It's challenging from my perspective to see what programs there are to help people make those changes on like a day-to-day life and see, it's important for me to reach out and make sure I've got access to resources. Like you said, to demand that you have access to care. It's something that comes with more technology, but the infrastructure is not there to support that demand. I'm wondering if you've ever seen programs that are there to fill that gap.
Programs that
Are there to fill that gap. So people are asking for more long-term care, perhaps, as they see that that's something they're entitled to, and then there's not much infrastructure right now to say we're going to fund your medicines, but I'm wondering if you've seen something.
I haven't seen organized groups of people asking for more, because they're limited by money, you see. They do know that there's other testing that can be done, but it just depends on whether their family can come up with the money for it, which is kind of a problem in our system, because we have so much that's available, and people don't see the cost of these treatments. And, if you spend a lot on healthcare, that means there's less for other important parts of our society, like education and our infrastructure. So I would say that the cost is usually what limits access to technology. And I haven't seen any major groups being able to organize and advocate for. I mean, the government, like, who would they advocate to? Like, it just seems the government is at a standstill, and basically people do what they can for their neighbors and for themselves. It's just kind of very short-sighted. I think they're just trying to survive just a little longer, It's very different.
I have a question. So speaking on costs, this is sort of a follow-up to my previous question. You mentioned how the government does nothing, and it's probably practically impossible to have any healthcare system in place. Just from your experience in Nepal again, how do you feel about the economy? I mean, that's one crucial, I think it's a crucial support to the government, and with a poor economy, is there any economic change in Nepal coming? Are there growths? Are they becoming richer?
Well, tourism is a major economic driver, and I think that's pretty stable. I mean, it's many people still come. Some of the, it's been relatively stable in rural Nepal in terms of crimes. They don't usually affect tourists directly, so I think that tourism is continuing to be a big driver of the economy. Nepal has very few resources, natural resources, so that's a huge problem. And Nepal has many young people who work outside of Nepal, like in the Philippines. The Philippines are kind of in a similar situation, but I think Nepal is actually the country that has the most people, greatest percentage of the population that work outside of the country, and then they send money home. And that's a major source of revenue for Nepal.
So
I think it's 18% of Nepalis are out of the country at any one time working, in the Middle East mainly.
So they're sort of reliant on international money, I guess, in that case. Like there's not a lot of self-sufficiency or home industries in Nepal?
No.
Do
No.
you- Is there potential for that? Like perhaps foreign companies could. I see like that could easily transcend to things like sweatshops and abuse of workers. But do you see any like foreign investment in Nepal possibly changing the course of their economy and the government?
It's not like Bangladesh. Like in the garment industry, I haven't seen that. Do you know, Kim? Like, I don't think there's a lot of foreign investment like that would employ people in Nepal. It's more the foreign aid that seems to come in. I mean, some of it is very good. Like at this hospital, there's Jim Simons, who made billions of dollars in the stock market, a mathematician. He's donated a lot to like develop a new wing in the hospital. And that certainly improves health and education, also education of paramedics, and that, I mean, that's very important. But I wouldn't say it employs a lot of people. It's, I haven't seen that. I'm sure there would be many barriers to setting up a company in Nepal, particularly in terms of having to pay off government officials.
So I think for a lot of very sound reasons, we should probably end early. So if you wouldn't mind, we'll end 6 minutes early. Thank you very, very much for an outstanding session.